Now we've got a little time for questions, and I must say they're flooding in. And we have to start with a statistical question because it's what data is all about. So, from my friend Peter Diggle from Lancaster to Maria, is there any evidence that risk of severe disease and death increases with age more quickly? For example, becomes higher at a younger age in low middle income countries. So there's a statistical challenge.
Well, I can tell you that the risk of severe disease and death rises dramatically with age. If you look at the crude case fatality ratio, but more importantly, if you look at the infection fatality ratio, there's a dramatic increase as age increases. Underlying conditions also complicate this. People with underlying medical conditions like chronic renal disease, chronic liver disease, chronic respiratory disease, HIV, AIDS has come out in a recent study from Africa, obesity, diabetes. So the short answer to that is yes, but I'm not a statistician, so I always make sure that I don't go into too much there. But this is a deadly virus. It's a very dangerous virus. It has been from the beginning. The Delta variant is that much more dangerous. But again, there are factors related to death from infection, but also about the care that you can receive. So if the healthcare system is overburdened, if that medical professional doesn't have the opportunity to spend as much time with you, your risk of death also increases. If you don't have access to supplies and oxygen and all of the tubing that is required to deliver medical grade oxygen, all of this factors into increased risk of death.
You could always, Maria, ask Peter to produce a report for the WHO on it. So there we go. Kick it back to him. There we
Next
go.
time. Next time.
So we've got a question from Georgina Humphreys, a good question. And this is to Devi and to Maria. What are your reflections on how data has flowed from countries to WHO and beyond through the pandemic? Have we got the data access, data sharing algorithms right?
That's a complicated question. That's a complicated question, and there's no short answer to that. I mean, certainly no. I mean, we have data that is shared with WHO. We have had challenges throughout the pandemic with many member states, not just with China in the beginning, but with many member states on the sharing of data. Disaggregated age, sex, information on health workers. It's very difficult to have the systems in place to be able to rapidly share that information. Some countries have it well in place. We do have the mechanisms through the IHR to share this information. And so I would say it's mixed. What has been impressive to me, really impressive to me throughout this pandemic, is the ability of scientists to share information rapidly, as quickly as possible. I was on that mission to China in February of 2020. And that information that we learned there, what we put in that report, I've been on dozens of missions for WHO, and we've never produced a report that has that much new information. I felt like I was writing a scientific paper when we were doing that. And the elements that were in there was new. They were new information. We've done lots of missions to countries by our staff and by international team members. And so we always need more. We always need more, and the mechanisms can be improved. There is an issue with the Delta variant now. So the stigma associated with countries, reporting information on the variant. Remember, people were calling this the UK variant, the Kent variant, the Indian variant. We changed that nomenclature specifically, one, because it was difficult to say B1617.2 and all of that, but also because of the stigma. And if we have countries that are afraid to report because of travel restrictions or because of political fights, this hampers our ability to know what's out there, whether this is epidemiologic data, variant data, clinical data. It's built on trust, and it's built on, and it doesn't happen overnight. So we have a lot of different mechanisms by which we gather information and data to make decisions, to inform. We do have member state briefings every week where a lot of information is shared, but it can be improved, no doubt, and to make sure that it's done earlier.
Okay, we've got 2 minutes left. I'm going to get two very quick questions in because I'm sorry we we could go on all day. So Margaret, what is the best example of patient involvement and engagement in health data science that you're aware of?
That's a difficult question. I mentioned the ONS, and some of our members have worked really well with the ONS, and what made that, I think there's something to say about what is patient involvement and what are the features of it that make it good quality, and one of them is actually listening. So if you have a conversation with patients, you may have done patient involvement, but then again, you may not. It depends whether or not you've taken on board what they've said, listened to them and amended things accordingly, accepting that not everything can be changed, but you've had a transparent conversation about what can be changed. And I think that's what happened with the ONS. But I don't want to say that it's difficult to pick best, because there are aspects of this, and there's work ongoing with various health data scientists, and sometimes it evolves as well. Sometimes you start off in a different place and then work towards something. So I can't really pick out another example that I would say was better or worse, but I think the key thing is that you sit down with a group of patients with the view that if they disagree with you, you're going to take that on board and reflect on it and possibly change it.
Okay, no, and you're beautifully selected, because Ian Diamond's coming on next, so we'll ask him about the public engagement impact from the ONS perspective. So we've got time for one very quick question, and I apologise that we haven't had time to challenge the panel more. But what we've seen through COVID is thousands, this is from Kit Bayat, thousands of published papers relating to the pandemic with variable quality. Do the panel think that the publication of preprints has been a good thing? And how can we balance the equation between speed and cost? So maybe ask Devi to quickly comment on that and go to Maria.
Yeah, so I think actually generally it's been positive to have more science, but it's how it's been picked up by the media that I sometimes worry, and that we need to have more scrutiny. Some of that has been through things like in the UK, the Science Media Centre, which has asked scientists to comment almost like a peer review of articles before it goes out to the media. But generally, I think it's been good to have it. And it's not like, I think Maria said, it's just because it's in a peer reviewed journal that means it's actually more solid than a preprint. But I actually just wanted to jump in. I know we're short on time, Andrew, on the question on country sharing data, because I know those at WHO are constrained in what they can say and not say. And I actually think there's been two problems in terms of data sharing. So I'm going to jump on that one for 2 seconds, which is around politically and technically. So I think it's been a technical issue, let's say countries like India, when actually we didn't get enough data on Delta and what it was doing in terms of hospitalizations, patient profile and others, because they just don't have the sequencing. So there's a real issue around not having the technical systems in place to be able to do it. But with China, I think there is an issue around that they were very cagey over what they were sharing. Both in December, you saw how they treated the whistleblower in terms of not wanting to get word out there was something SARS-like happening. But again, actually, the sequencing that emerged from China was not through the Chinese government. It was through a Chinese scientist sharing it and putting it online so that test kits could be produced and the sequencing would get out for the world. So in a way, scientists had to overcome and share even when there was government kind of screening and not wanting to share that at that point. And eventually the government did, but it took several weeks. So it has, I think, they're political and technical issues. So I'll stop there.
Okay, thank you. I'm really sorry. I've counted about 50 questions here, which we will publish. So thanks to everyone for contributing. But we're going to have to move on. And as ever, I will give everyone a virtual round of applause for a fantastic panel. Devi, Maria and Margaret, absolutely fantastic. And what we'll do is seamlessly move on to two stellar examples of harnessing data, multimodal data across the UK.